Uh, my name is Peter Young, and I'm the Yale class of '74, Branford College. And I'm very pleased to welcome you to the 17th in a series of panel webinars on careers after Yale that we started about 3.5 years ago. And the purpose of the series is really to focus on providing students and young alumni with candid views of different professions via panels of successful practitioners in each field. The overall concept has been to cover professions that Yale graduates pursue both in large and small numbers, but also in particular where there are myths and misperceptions about what the profession does and where it's headed, and what kinds of people do well or are happy. I can't emphasize the fact that TV provides distortions about all sorts of professions, whether it's forensic science or medical field or working for a law firm. So our purpose here is really to allow you to get kind of a balanced view from people who have a variety of different experiences in the profession. So today's profession is the medical profession, and we have had thus far for the first 16 panels 1,841 students and alumni attend, and an additional 2,600 have watched the recorded videos of the last 13. So total 4,440 have either seen it live or seen it recorded. Thus far, we've featured legal 2 times, investment banking twice, medical twice, consulting twice, internet and data services, entrepreneurism, drama and film, education, government service, nonprofit organizations, investing, and we had one panel on comparing investing, investment banking, and consulting. And for those of you who are listening who have an interest in the legal profession, our next career panel will be on November 10th, covering the legal profession, which will start at 4:30. What's somewhat unique about this event is that we have 3 simultaneous venues. We have the meeting room here in New York, where it happens to be, in this case, we have our panelists here. We have a room at Yale, where we see all of you via video conference. And then we have a large number of people who are participating by streaming video. And we're doing this for a simple reason, and that is the students are up in New Haven, the panelists sometimes are up in New Haven, sometimes in New York. Alumni are everywhere, and so by doing it this way, we really allow everyone to participate. I'd like to make 1 or 2 introductions before we start. First of all, up at Yale, we have Kristen McJunkins of Yale's Office of Career Strategies. She's at the Yale location. She's responsible for medical careers. Kristen, do you want to wave your hand there? There we go. You see her. And she also has the responsibility, when we get to the question and answer session at the end, of coordinating questions from New Haven. Last, I want to thank a number of people and organizations, because this is a collaborative effort, as you can tell. First, I'd like to thank Elaine Mazzarella and the staff at the Yale Office of Career Strategies, Steve Bloom and Elizabeth Rocher of AYA, Trish Takemoto, who is here in the room, who works with me on this, from the Association of Asian American Yale Alumni, Mai Lu of the Yale Alumni Association New York, the Junior Class Council, and others. And obviously, we all work together to plan and market this event. And last, I want to give a special thanks to our host here in New York, Sherman & Sterling, who has provided the use of this meeting room and the video conference equipment. And as many of you know, certainly if you know anything about the legal profession, they are a leading global law firm serving many of the largest public and privately held corporations and financial institutions in the U.S. and abroad. And Yoonji Kim, an attorney at Sherman & Sterling and a Yale graduate, was kind enough to arrange the use of this room. So what I'd like to do is this, in terms of logistics. I will first introduce the panelists and guide them through the 6 questions outlined. At the end, we'll open it up for Q&A from all of you. For those of you who are participating by streaming video, obviously you won't be able to raise your hand. We'd like you to send your questions via email to yalecareerpanels@gmail.com. Those of you who are here in New York or up at Yale, obviously you should just raise your hands and we'll call on people. And we do expect to end promptly at 5:30, but those of you here in New York, our panelists have agreed to stay on after 5:30 to talk to you if you have questions. You've seen the invitations, so I won't repeat the biographies of the three panelists. But to my far right, we have Dr. Stephen Dolgen, who is a professor in surgery and pediatrics at the Hofstra NS North Sierra LIJ School of Medicine and a Yale graduate. To my immediate left, we have Dr. Nathan Case, who is a professor in Department of Obstetrics, Gynecology, and Reproductive Science, and a professor in Department of Medicine and Dean Emeritus at the Icahn School of Medicine at Mount Sinai, and a former Yale Medical School professor. And to my immediate right, we have Hannah Hoffman, who's a fourth-year medical student at Hofstra North Shore LIJ School of Medicine and a graduate of New York University. So with that, let's get started. And what I would like first is just to ask each of the panelists to take a few minutes and just talk about, how they got in the profession and where they are now.
You're looking at me, Peter?
Yes.
Peter, is there a way to turn off the sound that's coming from Yale because it's distracting? Is it possible?
Here we go. We're turning it down. Okay.
You've all been muted. You can say anything you want now.
Yeah. Okay. Terrific.
I went to Yale College in a turbulent period, and it was turbulent politically, nationally, internationally, the late 60s. And for me personally, I majored in philosophy and graduated in 1971. I didn't take a single pre-med course, and there was no such thing as a post-bac program. I lacked a sense of self-worth, and I found an equation that worked for me, which is that if I could help an impaired or injured person, innocent victim of some trauma or disease, that if anything had meaning, that would have meaning, and that it would take a substantial effort to become good at that, and if I could become a go-to person in that way, that I would feel better about myself. So this was personal salvation, what Professor Harold Bloom used to call a vocation, a way to get salvation. And that was a self-fulfilling prophecy. The pre-med office was happy to charge my father for the courses. It was an ad hoc post-bac program, and I took biology and chemistry and the prerequisites, and I became a fierce student because I was saving my soul, and it was a self-fulfilling prophecy.
Okay.
How did I do, Peter?
You did well.
Thank
Hannah?
you.
I'm Hannah. I grew up in New York, and I went to NYU for undergraduate. I'm currently a fourth-year medical student at Hofstra North Shore LIJ. I am applying now for residency in general surgery. I fell in love with surgery since I was young. My father is actually a plastic surgeon, and it's just a feeling that you get when you see the bowels or when you see any type of operation, and you know that you fall in love and there's nowhere else you'd rather be. And that's, I think, what you can hope for in finding a profession, just that you feel as if there's nowhere else you'd rather be.
Right.
Thank you, Peter. Nathan Case here. I guess I chose medicine reluctantly, grudgingly. I was raised literally in a brownstone in Brooklyn, New York, where my dad was the GP for the community then called Crown Heights. He settled there, moving from the Lower East Side to Eastern Parkway, where they had not yet built the IRT New Lads line. So we were very much early Brooklynites. And as such, growing up in that brownstone, I just remember being part of medicine, sitting with the neighborhood families in my dad's waiting room and being impressed with how much they interacted with my dad and how much he gave to them in terms of solace, support, direction, in many ways other than medicine. It was very, very impressive. But I resisted it because I thought perhaps I was being too directed and too narrow-minded. So I was a humanities major at Columbia College till I said, what in the world am I doing? I want to do medicine. I want to be my dad, an altruistic, moral, ethical, giving individual. And I haven't quite reached that goal, but I'm trying. I love medicine. I would do it again if that's the question in your mind. You may have had others that deny that. There's just no question about that feeling.
Let's start with the one question. Since I'm involved in investment banking and in healthcare and chemicals, so I've seen a lot of the changes happening in the healthcare system and so forth. So there's a lot of change happening, good and bad, I think, when it comes to being a doctor and so forth. Could each of you anyone comment on where you think the profession is headed, good and bad, right? Because there are good and bad things happening today for the medical profession. You want to start, Hannah?
Sure. One of the things that I'm actually really interested in is global health. So I'm spending 3 months this year in Uganda. North Shore LEJ has a clinic there that's actually staffed 11 months out of the year with residents. And I think when you're looking at where the profession has been and where it's going, I think it's an important thing to consider healthcare abroad. And I think that there are certain things that we can learn from healthcare in other places, and there are certain things that we might not want to learn from them. I think that investigating pricing and different price points in different parts of the world is really important in order to improve on that for us and as well as for them. I've spent some time in Tanzania looking at how family structure, family dynamics deal with HIV and AIDS there, and how maybe we can improve on that. And I think that's a big issue to look at in the future, how healthcare abroad shapes our information on healthcare here.
Steve?
Well, let's see, Peter, the access to information that with which everyone is familiar and which people younger than I take for granted dramatically affects learning of medicine and the practicing of medicine. There's so much increase in the basic knowledge, and there's still yet so much more to know, so that's presumably going to just continue to become an unreachable goal to master the available information. However much you learn, the amount to know is growing faster than what you can learn. So I think the technology that allows access to help solve problems has had an enormous impact. And it's very clear in the medical school. The way anatomy can be taught today is so much more efficient than the way I learned it, because you can have a cadaver and try to make sense of the cadaver, but then right next to the cadaver you can have cross-sectional imaging with people trained in the cross-sectional imaging who can show you where the organs reside. And not only that, but that's the kind of tool you'll be using as a clinician in the future. I think of the notion of the doctor like my dad and Nathan's dad as who are long gone, but a courageous solo practitioner, adored figures, heroes, those kind of. I don't take that lightly, and it influenced Nathan. It influenced me to become doctors, but that's changing and will continue to change because it's a team sport now. You're still appreciated and recognized if you can help solve the problems, but you are so dependent on other specialists, and you're so lucky to have them. I have the hardest time envisioning what it's like to practice medicine in the boondocks, far away from these universities, which have the brilliant specialists, more than you can imagine. The pathologists and the anesthesiologists and the imagers and the child life specialists and the psychiatrists. It's the medicine in the cities, in the big centers, is a team sport.
By information, I first thought you were going to talk about my primary care physician says, you know, people come in and they Google everything. So it's good and bad. It's good because they're more educated. The bad news is they spend a lot of time self-diagnosing and so forth and second guessing. So I thought you were going to say something about that. Dr. Cave?
Peter, you asked a very, very important question, and I could spend the next hour and a half just answering it. Where are we going? Let me start with the facts. I graduated from College of Physicians and Surgeons in 1955. At that time, there was no Medicare, no Medicaid. There was no MRI, no ultrasound, no laparoscopy, no birth control. Contraception was illegal. We had an idea that men who had sex with men had a disease, but not really an understanding of the process of contagion. So if I ever had the hubris to say, I know where this field is going, stop my microphone. But I think there are certain very clear directions, and you all out there that are looking forward to a career in medicine, I hope, need to understand that what you see today ain't going to be that way 10 years from now. The practice of medicine will be very, very different. It will be a team sport. The all-pro GP will be the master of the team, but not alone. There will be hospital-based doctors and community-based doctors, and they won't really communicate beyond sharing patients. There will be a whole raft of new therapies based on immunology, based on stem cell understandings, small molecule interruptions of the mechanism of disease. There'll be a heavy and necessary emphasis on prevention. The point of my comment, Peter, is there are two features here. One is that will never stop, and that's the defining feature of medicine, altruism. But the second is response to change and applying the new science directly to the care and outcome of populations and individuals.
Now
It's an exciting field.
let me be a little bit of a devil's advocate, because we're getting a little bit of cheerleading here. There are a couple of things to think about. One is,
You noticed that.
I noticed that,
Yeah.
so we're going to have a mid-course correction here a little bit.
Yeah.
Let me
Bulldog,
report. So
bulldog.
let me say some things that I hear from people in the profession. One is there's a reason why sole practitioners can't practice anymore, because the costs and the paperwork associated with running a doctorate become so onerous,
Yeah.
and it's driving pretty much all the people I know who are doctors to no longer have their own practice when they end up working for hospitals for a salary. That's a change. Good or bad, hard to say. The other is that there's tremendous cost pressures on the healthcare system because healthcare, all these inventions, so forth, also have had the effect of raising the cost. So now there are lots of pressures on pricing and on reimbursement and so forth. And the other, of course, as we all know, that in this country, I won't speak for other countries, people get sued a lot, and doctors get sued a lot. So these are at least three things that are realities that weren't true 30, 40 years ago. You know, would you agree with that? And are there other things that and these are things that you have to think about, because, you know, if you come out, like you said, out of medical school, you're not going to have an individual practice in New York. It's unlikely, right?
Peter, I very much appreciate your instructions and your vision for the panel, which is you want balance, you want
Yeah.
pluses and minuses, you don't just want to hear cheerleaders. And I'm not going to address the specific things you just raised, not this second. I just want to say this, though. My hugely respected colleague, Dr. Case, looked at this group of young people, said, I hope you're interested in medicine. Well, I don't. I don't. I hope those of you who have a solid idea about this and the right motivation, I want to help with that. I want to help with that. Medicine is such a broad field, so that people real interested in science think, well, gee, I could make a living doing that. I'm real interested in science, and I don't see getting a PhD in molecular biology, and I don't see making a living that way, so I'll go into medicine. Likewise, medicine is very humanistic. Just listening, it's very humanistic. So people who have beneficence in their heart, but would never want to face the realities of people dying or angry, those people shouldn't go into it either. So I think that the ones I would encourage are those of you looking for a vocation, not a job. I mean, to really help define yourself, to put meaning in your lives through lifelong study, and a willingness to enter a very personal profession. There's a lot at stake where you are going to be wrong. Those of you particularly interested in mathematics and science will be surprised at how imperfect clinical medicine is. It does not strictly follow mathematical rules. These scientists have a huge impact in medicine, and it is possible to get an MD and become a basic scientist. But if the goal is to be in the clinical arena taking care of patients, you need to be a person who can share your views and make decisions that are imperfect and are sometimes wrong.
Let me take the next question.
No.
Well, wait a minute, Nathan has
Wait
to
a
say
minute.
something
Okay.
now.
You asked specifically about 3 areas.
Yeah, go ahead. No, I gave them as examples
Tort
of things that are
reform.
less positive about being a doctor, right?
Okay. I'll answer it very quickly. I hope succinctly, accurately. Tort reform is necessary. That needs to be looked at very carefully. It's a political situation, but even the best doctors do bad things or get into trouble, and the patient needs some response that's appropriate. And that's got to be managed properly. There is an enormous amount of diversion away from the care of patients by data, by insurance, by clerking, various things. That's got to stop. 25% of every dollar in healthcare goes to the insurance companies. Now, it's a big industry. It employs a lot of folks. You ain't going to change that too fast, but clearly, single payer system is what you all, if you go into medicine, need to push for and realize. Finally, you're not going to get rich. And what that says is you're not going to necessarily pursue high-paying, high-income fields, because eventually everyone is going to be paid well, but not exorbitantly. There will be abilities to live well, to have a quality of life that you will find very, very comfortable. But the enormous monies that have been made in medicine are gone, and that's a good thing. And finally, how shall I say this? the motivation remains, if you want to invest your personality, your personal view, your sense of self-mastery and authorship, uh, altruism is the right route to take. And I know I'm cheerleading, but my feeling is that's a very rewarding thing that's rare in most professions and most pursuits.
I was thinking the same thing as Dean Case. I mean, if you're doing the right thing for your patient, that's what's most important. And I think
Bingo.
I'm young and naive in thinking that sometimes, but if you're thinking about insurance companies or money or whether you're going to be in private practice or work for a hospital, that's really not important, especially at your stage and my stage. It's just the bottom line is you want to do what's best for the person in front of you, and I think that's the attitude to kind of have when you're starting off.
And Hannah, let me add to that. One of the things, well, two of the things we need to solve. One is costs. Are we going to answer demand or are we going to answer need? And finally, we've got to solve care of the elderly and end-of-life care. We can invest ourselves as the profession to help solve that very, very difficult moral and ethical problem. It's absorbing a tremendous amount of money. I'm sorry, that sounds crude, but it's true. And that needs to be looked at, examined, and corrected.
Well, let's move from general policy to individual careers. And I actually have a question for you because you were a panelist before, and you actually addressed. I asked you a question that it was very helpful to the audience because you once were running a medical school, right?
Yes, indeed.
So one advantage you have versus the other two panelists here is that you were part of the process of selecting who to take as students. I know last time you said here are the kinds of things that we look for in deciding, who should be admitted to medical school. So if you could comment on that, because that's actually very important, because these are characteristics, because obviously you're doing that to figure out who would make a good doctor, right? And who would do well at the medical school. So can you comment on that?
I'd like to think that what I'm going to say is accurate, true, and true of medical school admission committees throughout the country. But the fact of the matter is the applicant pool available to our medical schools in the United States is so large, so rich, so able and smart. We could throw darts at the board and not miss very much in terms of the quality of our students or our graduates. That's not good news to you guys because the person sitting next to you is going to be almost identical in terms of how appealing their background, etc. So having said that, what's going to make the difference to this former dean when he or she observes a candidate? I know they've got every kind of ticket that I can imagine. Hey, I wouldn't get into medical school today as far as I know. I look for someone who can speak logically, cogently, and to the point. I look for people who have engaged in difficult tasks and executed them to completion. I look for people who have an understanding of something outside of the profession: theater, art, music, politics, economics, divinity, theology, etc. I look for the richness of background because that's going to be the communicating link between you and your patient. They're not, any of them, going to be quite like you, and you need to be able to communicate with them cogently and explicitly in their terms. Um, so those are the elements that I consider as differentiating from the mass of similar brilliant guys that you represent.
Let's move to the next question, which is very specific, which is all professions have both myths and realities. Every profession that I know of. You happen to be in a profession that has more myths than typical because there's so many shows on television and movies about being a doctor and so forth. Just cite one myth versus reality that you can recall that is useful for people thinking about being a doctor. Do you want to, well, Hannah, do you want to start?
I would say the reality is that it's hard. I mean, no one will tell you that it's easy. It's hard. I mean, medical school is hard. But I would say the myth is similar in that it's impossible. It's not impossible. I mean, I got married in June. You can do it. You can have a family and you can have priorities and care about things besides for medicine. But you have to make a commitment to yourself that this is what you want and this is going to be your life. So you can have things on the side, but it's hard and it's difficult to manage, but it's doable.
Steve?
I guess the myth is that physicians should be perfect, never make an error, never be unsure. That's tragic because we ain't. And the biggest error in dealing with that myth is we try to hide it. I think that TV probably has overstated the super qualities of medicine. I'll do anything in the ER, my God, including brain surgery. Madness. Those are things that are just unbelievable. So the myth really is perfection and
And you can't always solve the problem, right?
but you got to be truthful about it.
Yeah. But on TV, every 15 minutes, you solve at least one medical problem, right? Steve?
Well, so I think that this concept of altruism has a mythic feature, which is that the altruist is sacrificing things and suffering, the lack of enjoyment, the lack of hedonism, the lack of a warm, good feeling, because the altruist, by definition, gives up those sorts of things to help others. Because what I think the altruism in medicine is about is a narcissistic reward that you get when you help somebody. And if you haven't figured that out, if that it doesn't come to you, maybe you're not suited to medicine. But the psychic remuneration when you help people is extremely appealing to your ego. And so I think there's a little subtle notion that the great doctor is somebody quietly leading an ascetic life without pleasure, when actually it's the contrary. Wait a minute, I want to hear what Nathan said.
You have just heard a classic great surgeon talking, guys.
Wait, what? Well, I see you're amusing yourself, Nathan, but what do you mean?
Absolutely, altruism is a reward, and yes, there is an enormous power that derives from your ability to cure, heal, correct, and it's not narcissistic, it's real. It's satisfaction that you've applied your abilities to the health and welfare of another individual. That's altruism. Hey, I can have a good time after I've taken care of that patient.
Let me ask you this, since every profession has people who end up feeling they made the right decision and they're happy, and every profession has people who end up finding out that they don't enjoy it, and it may or may not actually relate to whether or not they're good at it. I mean, I think I think there are people who probably find out they're a good doctor, but they're not happy. So let me ask you this question, because you know, two of you have been in the profession for a long time. You've been for 4 years, so you're long enough to observe people who decided it wasn't the right thing, and so forth.
Yeah.
What are some of the reasons why people end up either feeling it wasn't right for them, either because of the skills or because it just wasn't a fit with them and they couldn't be happy? Hannah?
I would say the most important thing that I've seen is flexibility. When you're training to be a physician, when you're thinking about being a physician and dealing with people, I think you really have to be flexible. And I think when you think about women in surgery, I think that's pretty much the last thing that comes to mind, most likely, right? You think about type A, classic, really bossy or really opinionated, things of that nature. But I don't think that works well. And I think that's why there could be some problems or dyssynchronies. But I think what's key to remember, more than being competitive or smart or technically skilled, is flexibility and being able to adapt to situations.
So you're saying people you observe who end up not happy were people who were not flexible enough? Is that what you're saying?
Yeah, people that are not flexible enough, or they need everything to be a certain particular way in order to succeed, and things are just not that way. And when you're becoming a physician or a surgeon, you're not always presented with the same situation. You're not always presented with the same problem, and you can't have an algorithm to solve each thing. Although it might seem like that in first and second year of medical school when you're memorizing these algorithms, it's not always appropriate. And I think that people that are too rigid, even though they might be really smart and be aware of all the appropriate things to do at the appropriate times, I think it's important to be flexible and be able to adapt to things that come up that are not relevant to what you studied or memorized in a textbook.
Yeah. By the way, I do want to make one point related to what you're saying, which is, although what these three panelists are talking about are the profession and characteristics and so forth, which hopefully are helpful to you as you think about you know, whether to go to medical school or, you know, so forth. One thing, of course, is to do something that actually Yale doesn't really help you with, which is a good self-assessment of yourself. So, I mean, the reason I mentioned is you're saying one characteristic is, are you flexible, are you rigid, so forth. Well, you know, if you don't spend some time thinking about self-assessment and understanding yourself, you may know a huge amount about the medical profession but make the wrong decision.
Right.
So I would just encourage all of you to find a way, with the help of friends or others, to do a proper self-assessment about what makes you happy, what you're really good at or not good at, because you got to compare it to each profession, right?
Absolutely.
Steve?
You know, Peter, go ahead, Nathan.
Well, you were.
Peter, you gave a scenario, a hypothetical a while back about somebody real unhappy in medicine because they're finding themselves unable to make a living, totally distracted by the bureaucracy, they're surprised by the paperwork. And so I think that a good thought for you all, when you run into a doctor like this, and there's no question they're around, there are doctors who are whining about it and regretting that they went into the field. Those people may not have insight into what was the matter. They may not. And the way I would listen to them is what went wrong in their careers that they're suggesting, and what they may have chosen the wrong career. And maybe I can learn something from that. Because, for instance, if they went into the field thinking it would be an easy way to make a lot of money, and it's very simple to see if you're failing to do that. You can quantify that. If they went into the field thinking this will be an easy way to make a lot of money, and that was their motivation, they probably went into the wrong field. Then again, if they went into the field because they loved science, and they're uncomfortable with the sorts of things Nathan was talking about, the sorts of things Hannah's talking about, dealing with people of all kinds of ethnicities and socioeconomic status and sexual preferences and late at night and doing self-injurious things, and yet you're supposed to help them. If you're not comfortable with the murky, inchoate nature of the human species, you may not be suited to a clinical career.
Yeah, actually, to correct, I didn't cite an individual who felt those three things are happening. I said those three things are happening to the profession: extra paperwork, so forth.
Okay,
I wasn't
yeah.
citing an individual.
All right. Well, we do hear that.
I was citing what's happening to the profession. And to be honest with you, you know, on this issue of paperwork, you know, my own personal doctor basically says, it takes a different view than what you said. He said, all this paperwork is taking me away from treating patients. So he's not saying, I want to get rich and,
Yeah.
paperwork. He's saying, this is imposing, things are getting in the way for my doing
Yeah.
what I want to do as doctor. So it's actually quite the opposite. So a lot of the things that are happening are imposing things that are getting in the way from doctors to do what they want to do, right?
Peter, I'm going to answer that very quickly. That's the ripest opportunity for some smart computer guy to just electronically deal with record keeping. Make it so it's possible to check, to do a digitized, a yes, no. Make it possible for an assistant to record. There are solutions, and there's ample evidence. Let me get back to the people that have not whined, but have changed, okay? There are three kinds. One is the individual, oh, he's looking at his watch, and I am
No.
loquacious.
I want to
No.
make sure there's enough Q&A at
Yeah,
the end,
okay.
that's why.
Yeah, I know.
I'm not thinking
Here's-
about you.
Here's the deal.
But I will
Uh,
look at my watch again for the same reason. We
yes,
need
I
10 minutes.
understand.
We need 10 minutes at the end to have
Yeah,
Q&A.
okay. The guys that leave medicine and go get a business degree or a law degree, because that is what interested in them, not care of patients. The second group, alas, are the victims of change. The older physicians that have their routinized methods of care. I think you've seen them in surgery. They have been displaced by the super surgeons, by the super specialists, and they are left alone and unhappy, and they retire. The third is a much more serious problem, though not the others are trivial, is the burnout of young and old. The burnout not to leave the profession, but to change their motivation. To talk about patients as bad people rather than people in need. Eventually, recidivism, indifferent to self-care, whatever, gets to every physician. You need to be, Hannah, you're quite right, flexible enough to have the resilience. I can deal with this. I can learn from it, and I can help this. There are some things you can't solve, but even there, you need the resilience of purpose to be able to continue and to follow your ideals, not to lose them.
So we've reached the point where we have to do the Q&A from the people who are at Yale and here, and also I already have a couple of questions from those people who are doing the streaming video. So let's start with the students at Yale. Kristen, can you act as the sort of coordinator there?
Yeah.
Do we have any first question from New Haven?
Hi. So my question is, what other non-science classes or topics do you believe are most useful for a career in medicine?
Nathan, did you hear the question?
Not completely
I
intelligent.
I am going to say that we were asked what kind of courses, college courses, outside of the sciences have been most helpful for physicians. Did I get your question right?
Yes.
I have to tell you, I'm going to admit to a really serious bias. I think reading great authors, reading gives you the parlance, the vocabulary of communication, but also the sense of cogency and directness. And you know, there is kind of personal style that you develop. I happen to think Philip Roth is a genius. I happen to think Joyce Carol Oates is just unbelievable. But for me, those things equip the physician-to-be with, let me start this way. At your age, your sense of the joys, the sadness, etc. of an individual's life are intuitive. By reading, you get the larger picture that expands your understanding and helps you correct your own misunderstandings. So for me, reading, great literature is not only informative, it develops a style of presentation that is winning, even to admissions committees.
Is there anyone who has a question here in New York who would like to ask a question?
I have a question.
Speak louder just so
Sure.
they can hear.
So a lot of the improvements to the profession that you mention are policy overhauls. And I wonder how much political power or power for change do you feel you have just in the day-to-day?
Are you addressing that to me?
To
To
anyone.
everyone.
Yeah.
Could they hear that question in New Haven?
Well, the question is, how much clout, political or otherwise, does the medical profession have to solve the obvious difficulties in a damaged, broken healthcare system?
On a day-to-day basis.
On a
He's saying
day-
on a day-to-day basis.
I can tell you the proof of the pudding is very little. It will take the patience. It will take, alas, a social upheaval to correct many of the deficiencies. But you know what? You do make progress whether you like it or not. The Advanced Care Act is a powerful new step in at least opening access to care to millions that didn't have it before. That doesn't mean they're going to get good care, but it's better than nothing. So I'm old enough to say, my goodness, things change, but not today or tomorrow, and maybe decades, but one has to have some faith in human direction for the good. But we don't have.
One thing that would respond to both questions. One thing you can study is you can read Paul Starr's Social Transformation of Medicine. I probably have the title wrong. It's about 30 years old.
Yes.
It's really dense. It's the kind of thing that professors at Yale are happy to assign to you, thinking you can actually get it read. You could read Steve Brill's Bitter Pill, America's Bitter Pill, which is much, much more readable. You could get yourself interested in the politics of healthcare distribution, the finances, and the economics. I think the courses you should take, you should follow your heart. Even if there's an inspiring teacher and the subject is not necessarily something that you have a comfort level with, whether it be art history or rhetoric or drama. One of the wonderful features about being in New Haven as an undergraduate for 4 years is the fact that you can study things that you might never get to study again.
It occurs to me, though, we ought to be very careful getting into politics because the evidence thus far of doctors who are politicians is not entirely persuasive that we're doing the right thing.
If
Well,
I could
maybe
just-
we'll have Ben Carson in.
I
as
didn't
Ray.
mention.
Just on,
And he might solve. Hannah, go ahead.
It's okay. Just on a smaller scale, when you think about what you're doing in the immediate years to come when picking a medical school, I'm lucky that I was able to actually go to a new medical school. I'm going to be the second graduating class of Hofstra North Shore LHA School of Medicine. And I think it's something really important to look at about how teachers value you and how your professors might or might not listen to your opinions and your advice and what you have to say about this school. I think I've been in a unique position to be part of a new school, in which case attendings like Dr. Dolgen and others have sat and listened and say, how can we improve? How can your education be better? And I think that's important to ask when you visit medical schools or see people that have gone or different alumni and you talk to them. And I think that's really important. And also serving on the student council of your medical school. It sounds really fun and kind of like high school. But being president of student council for a couple of years now, I've really been able to work with the administration, and they have worked with me and kind of affected, minor but changes for the better and for hopefully for future generations of doctors. So
I have a question.
Just one follow-up there, Peter. Thank you. I think it's important to tell you, as a former dean, that all medical schools are great. There isn't a bad medical school that's approved in this United States. Get into any one of them, and it's up to you to make the most of it. The schools there, they're all very strong. So don't have a heavy, burdensome priority rating. They're all very, very strong, and they will give you what you need if you're willing to take it.
Well, if you get fired up at the most anonymous, least pretentious medical school, you will have saved your soul and be so much vastly better off than a disaffected student at one of the most illustrious.
Yes. Reputation is not the thing that makes it these days. I think you all know that.
You'll be next. I want to rotate through. So we have a couple of questions from people who are in the streaming video. There's a question here from Rosario Costenda, and I guess it sort of may relate to you, Hannah, because it's a question about women. So if you're a woman and want to start a family would need to take some time off from work, what is the best time to have a child? It's kind of an interesting question. But you don't have a child yet, you just got married. So,
Yeah.
but maybe thinking about other people you know who are women, how they feel about this issue.
Yeah, that's a very good question. Difficult question, but yeah, like I said, I just got married in June. I'm going to surgery, so surgery might be a little more difficult than other professions. But the bottom line is you can make it happen. You can take off a year and do research and have a child as well. I'm sure that's what I've heard of happening. It's a little early for me to kind of speak to that, but what you need is determination, which you probably have if you're going to medical school, but also commitment. So you're committed to having a family and you're also committed to being a doctor. So that's the most important thing. And if you have that, I don't see why you can't make it happen.
There's no question that the future practice of medicine will be a team practice. In OBGYN, perhaps the most diverting and energy exploiting specialty. There are groups. And yes, the patient gives up continuity, but has a very well rested and able obstetrician to care for her and her newborn. I think team medicine will obviate some of the issues that made the glorious past of my father unnecessarily and perhaps self-damaging. So I would encourage that understanding, and please, we need every candidate we can.
There's another question here in New York, and then we'll take another question at Yale. Go ahead.
Hi, I just want to say, first of all, thank you for all of your insights. They've been great. I want to remark and ask a question on the conversation earlier on narcissism and altruism within the profession. With the role of the doctor changing, and now there's the increase of physician's assistants and nurse practitioners, I was hoping you could remark on why choose the medical school route, why choose to become a doctor, if altruism is your main motivation over those other professions.
Could they hear that in New Haven?
No. Let me just try to repeat the question. She was saying, when you're talking about...
We can hear it.
Oh, they heard it.
Oh, you can hear it? Okay, great. So go ahead, whoever wishes to answer first.
I'll be happy to field it first, but Steve.
No.
We're getting some feedback. So
No, that's all right. Go.
Okay.
Yeah, go ahead.
Okay. The question is, Uh, do you need to be the sole, direct, hands-on deliverer of the definitive element of care? Or do you appreciate the complementary capability of your associates, the nurse practitioners, the PAs, the various people that make up the medical team? If the outcome is worth it, however you achieve the best outcome is the most rewarding. And that's, for me, altruism of the highest quality. So it doesn't diminish it, it just makes it more efficient and certain. Because we can't do it all.
So anyone want to elaborate further? No, okay. So, next question from Yale. Anyone have a question? Raise your hand and Kristen will call on you.
Hold on. Opinions on like allopathic versus osteopathic medicine and picking one over the other? Should I say that again? Sorry.
Nathan, I think she's asking allopathic versus osteopathic.
Yeah, and picking one, like how to decide between the two.
How do you decide between the two?
I have, if I'll feel that,
Yeah.
I think my experience is that DO and MD is hard to distinguish when they're good. A lot of very able colleagues of mine are doctors of osteopathy, and the old lines that were drawn are blurred so that, quite honestly, I don't even see them.
But wait a minute, Nathan, let me ask you a question. If one of the students is able to get into medical school, is there reason they should pursue a DO degree instead?
That's, alas, a problem of identity and prestige. It turns out, I think it will turn out in due time, that it won't make a difference because we need lots of doctors. But at the moment, I think most people would say go to a medical school because it's a ticket to a higher level entry point.
Look, if you can't get into medical school and you get into osteopathy school and you're driven, motivated, talented, you can have a very bright, rewarding medical career.
Yeah.
But you're going to have obstacles that you can overcome. But you have an advantage with an MD if you have the same goal.
Yep.
Yeah. The quality of the education, I don't know enough about.
Well, all I can determine, I said earlier on in these sessions that there isn't any different amongst American medical schools. I think there may be in osteopathy schools, but I don't know them that well. It all revolves and devolves to the individual and how that individual makes the most of the education. I can tell you this, Steve, that the DOs that I've seen at Sinai, and I see a lot of them, are outstanding and indistinguishable in their commitment and knowledge and capacities.
Well, look, last thing about this. If you're a DO because you were a late bloomer and you didn't nail all of the courses you needed to nail to get into medical school, and as a late bloomer, you got a fire in your belly and a brain in your head, strong heart, you can do fabulously well. But you don't set out on a course to be a late bloomer. It befalls you.
Happily.
Well, you're happy that you bloomed. You're not happy it was late.
or if you're deciduous.
Our next question is from Nick Grewal, who is online and streaming video. And the question is the private practice going by the wayside? And what is causing this shift? And is this a good thing for medicine? Hannah, you want to start?
It's a tough one. I think that most people now are looking to be part of some sort of institution or university when they graduate. I'm sure that these distinguished physicians can talk about it better than I can. My actually personal experience, if we're talking on a personal level, my father actually went into private practice here in New York about 5 years ago. And it's been hard. It's been very hard. He was the chief at Cornell for 20 years, and he didn't like the politics, which is something that goes along with being a physician at a large institution. And that's why he left. He left to go into private practice. But it's been very stressful on him. And when you're in private practice, you have to generate your own patients. You have to look for referrals, which you might not get if you're no longer affiliated with the hospital. And it's lucky that he's part of a profession which allows him to do so in plastic surgery. But I think that it's a larger question. I think that most people are now going to universities, and I think it also depends on the profession. Certain professions you wouldn't be able to survive even 5 years ago and now. But I think that's my personal experience with it. I see his stress, but
Private practice, in the sense that we understand it, is a dinosaur that's dying and will die quickly. It does not answer the vast needs of our population across this country. We need teams of medicine. We need medical homes. We need rational distribution of care between the consuming day-to-day practice as outpatients and the consuming inpatient hospital-based physicians. That is the changing format. Private practice denotes an office somewhere downtown where you have private patients. That's dead, or is going to be dead, unless we have a very special plan which allows individuals to choose at great cost individual care. We can't afford that, any of us.
But it does point to one very simple thing, which is you have to have a different personality if you work in a team versus on your own. So basically, one underlying part of this in terms of characteristic is if the individual practices where you're running your own doctor practice, so forth, is disappearing. So by definition, what that means is if you want to go be a doctor, you better make sure you can work in a team environment because the individual environment is disappearing. Is that a fair statement?
Yes, for sure. Fair statement. By the way, Peter, I believe the cafeterias have all opened in New Haven at the college. There's many people leaving and they look hungry. I want to say something to you guys. You're going to get better food someday than you get now in the cafeteria. You are. And you're going to have more fun preparing it and that sort of thing. You might have a big kitchen that you don't have there. But you might never have as many interesting people to talk to. I used to have so much fun in the cafeteria. Not much more than I had in class, actually. Somebody, by the way, Peter, somebody has a question there.
Is there a question there? That'll be the last question because it is 5:30, and Dr. Dolgen has reminded us that we cannot get in the way of a Yale student in their dinner. So there's a question?
I thought so.
Was there a question?
Anybody have a question?
Yeah, there's one there.
There's a hand.
Okay, one more question, and then we'll let you go have dinner.
I saw a hand over there. Yeah, where's that question?
Hi,
Here it comes.
hello. So you keep referring to medicine as like a team practice. Oh, can you hear?
Yes.
And I'm wondering, so I'm interested in family medicine, and I'm just wondering if you consider that part of practice, or if you see that being phased out by the specialties in years to come. Because I know there's a shift towards more like specialists instead of just general family practitioners, and I'm just wondering about what you think about that.
Good question. Interested in family medicine.
Yes.
Is there a future for it?
A necessary future, but I think the designation family medicine may be too broad. I think there will be a great need and application for individuals who have combined medicine and pediatric backgrounds. We need doctors in teams that are able to deal with a variety of patient needs. I don't think at the moment that the classic family physician who not only did surgery as well as delivered babies can do the job that we expect to be done in the future. So there will be multitasked, but limited to the ability to do it well.
I can comment on one thing, and that is the Affordable Health Care Act, which is called Obamacare. The way it works places a much greater need for the general practitioner. So you do have a crisis, which you have a mismatch between the number of, there's going to be a big demand because of the way that system works. So there's a mismatch, and how it's going to be solved, I don't know.
You don't need us to get an imprimatur to pursue primary care, frontline medicine. You need to be this is a world, my dad used to say they'll have doctors of the left retina. And he was regarded as a radical specialist, my father, when he was a pediatrician in a community that had all general practitioners. But some of the savvy you'll need to have is knowing when there is a problem you can't solve, knowing just enough to be able to get help. But it's widely understood to be a critical need.
Yeah, so the urban physician team will be led by an all-pro generalist, whether that's an internist or a pediatrician, but led a team so that more than just that all-pro individual is going to be caring for patients.
With that, what I'd like to do is, first of all, thank our three panelists who I think done a wonderful job of addressing a lot of very important questions. I hope all of you who are up at Yale and the people here in New York and those of you who are participating by streaming video have found this very helpful. I thought I had a diverse panel, but I now realize that along one dimension, it wasn't, because all three of you, your father was a doctor, so I failed in that regard.
Yes, right.
But it doesn't mean that you can't be a doctor if your parent wasn't a doctor. So thank you all, and I want to remind you of those of you who might be interested in the legal profession. That's going to be on November 10th. They're the guys who are going to make these guys miserable, so you might want to consider that. But anyway, thank you all, and I want to thank these panelists who did a wonderful job.